Okay.
Good morning, doctor. Today we're going to discuss about monoclonal gammopathy of undetermined significance. First, we need to know that this term was discovered in 1978 by Kyle and Grape, but this term wasn't really defined about it because it's really related to multiple myeloma, so we don't have the same criteria as we have today. In 2014, the International Myeloma Working Group, they decided to make a new criteria for 3 diseases, that is multiple myeloma, MGUS, and smoldering multiple myeloma. So here we are going to find the 3 diseases that I was talking about. The one that we're going to discuss more about today is the MGUS. We are talking about MGUS when the M protein levels is less than 3 grams per deciliter, the bone marrow has less than 30% of plasma cells, and we don't have any end organ damage. When we're talking about the levels of M protein that are more than 3 grams, we're talking about a smoldering multiple myeloma. In this case, the bone marrow is going to be having more than 10% of plasma cells, and we're not going to find end organ damage. And when we find that the protein is also found in serum, as in urine, the bone marrow has more plasma cells that between 10% and 60%, and we have clinical symptoms. We're going to be talking about multiple myeloma. So as I told you before, MGUS is going to be defined when the serum M protein is going to be less than 3 grams. The plasma cells are going to be less than 10% in bone marrow, and we are not going to be finding any symptoms defined by myeloma. What are the symptoms? The symptoms that define myeloma are hypercalcemia, renal insufficiency, anemia, and bone lesions. These lesions are going to be usually lytic lesions. In case of the epidemiology of MGUS, this disease occurs in 3% of the general Caucasian population that are over 50 years. It's usually a result of an incidental finding. It's not something that we are going to be looking straight away of this disease, but if somebody is having a blood test or they having a serum electrophoresis, they could find this disease, but it's not like straight away diagnosed. The mean diagnosis of discovery is going to be in persons that they have 70 years, and we're going to find that it's more frequently in men than in women, and it's more frequently in African Americans than Caucasian population. Also, it's important to notice that the rate of progression of this disease for malignancy for multiple myeloma is 1% per year, and this percentage is not going to be lower, it's going to be increasing by the years. In case of the epidemiology, as I told you before, the incidence is more in men than in women, and this incidence is going to be increasing by age. Is 120 per 100,000 patients when they have the age of 50, and is increasing when they get the age to 90. And in women is going to be increasing also with age, but it's less than men. In case of the epidemiology, we are going to discuss about that this more frequently, 3 times more frequently in African Americans than in Caucasian population. This is a summary of many studies that they did about MGUS, and we can find that this is more, they have more prevalence in Africa than in Italy, for example, or in USA or in France, because we have a more African American population here than in the other countries. The incidence of multiple myeloma is variable throughout the world, but we can see there in USA it has a high incidence than, for example, in another countries, Asia countries, they're going to be having less cases. This disease is usually sporadic, but there is an increased risk when you have a family member that have the same diseases, multiple myeloma and MGUS. And it's also discussed that we have a shared environmental and genetic predisposition. And this disease, you can find it usually related to other medical conditions. Some of them are lupus, immune thrombocytopenia, acquired angioedema, superficial thrombophlebitis, and the patients that they suffer from MGUS has an increased risk for fractures. We're going to be finding 3 types of MGUS. This is depending of the immunoglobulins that we are going to be having in the discovering in patients. The first one is going to be the NAM-M. This is related to MGG, NGD, or NGA. This is a more common subtype. And this subtype can be progressing to a smoldering myeloma when there is an increase of the levels of M protein and the clonal cells in bone marrow, and also can progress to amyloidosis and light chain deposition disease. Other case is the MGM disease. This is going to be the 50% of the cases, and in this case, it's going to progress to Waldenström macroglobulinemia, but it's going to be infrequent that this disease is going to progress to multiple myeloma. And the last one one that is recently discovered is the light chains. In this case, the M protein is not going to be having the heavy chain of the immunoglobulin. And this disease can progress to light chain multiple myeloma and also amyloidosis. In case of the physiopathology, we're going to find that this disease is like a spectrum of many diseases. When we have troubles in the somatic hypermutations of the B cells, we're going to be having MGUS. But when we discover that there's going to be translocation and DNA hypomethylation, we're going to be increasing the numbers of the plasma cell, and we're going to be finding a smoldering multiple myeloma. And when this rate of plasma cell is more than 60%, we're going to be discussing about multiple myeloma. As I told you before, this is going to, the physiopathology is not defined yet about the MGUS. But some of the mechanisms that are being discovered is that it's related to the bone marrow microenvironment, and also translocation of the heavy chain of the immunoglobulin in the chromosome 14 with the chromosome 11 that has the cyclin D1 protein that is going to be related to the cell progression. About the diagnosis of this disease, it's not something that we're going to be having straight away. It's something that is incidental. So the patient may be having a peripheral neuropathy, and we are studying the patient and we find that they have MGUS, or they have vasculitis, or they have skin rashes. We're going to be doing to the patient a complete blood count. We're going to discuss about the levels of calcium and creatinine. We're going to be doing a serum and urine electrophoresis. And we're going to be discussing about the free light chain to know for sure what is happening with them. It's important to notice that if we find leukocytosis, normal circulating cells, or something that tells us that we are having another disease, the diagnosis of MGUS is not going to be the diagnosis that we're going to say. This disease is usually without any symptoms, but we can have complications with the deposition of the immunoglobulin. One of the complications that we can see is fracture and osteoporosis. Fracture and osteoporosis are going to be 1.7 and 1.2 more frequently in patients having MGUS than in normal population. This is because the deposition of immunoglobulin is going to increase the osteoclastic activity, is going to be causing bone resorption instead of production of bone. And we're going to be seeing lytic lesions in case of multiple myeloma. And it's going to be more frequently infections and also renal disease. This is going to be happening because we have low levels of gamma globulin that is going to be helping us to protect from infections. And also the deposition of the immunoglobulin is going to be causing changes in in the renal area, and we're going to be seeing more renal diseases. And also, in this case, is 2 per 2 more frequently in patients with MGUS than in normal population. And net neuropathy is like we saw in the patient of, I think it was last week, is 5 per 9 more frequently in patients with MGUS than in normal population. And this is because we have an antibody that is against myelin-associated glycoprotein that is going to be causing the loss of myelin, and is going to be going to result in symptoms for the patient. And another complication is thrombosis. This is related to inflammation and the increased levels of interleukin-6. So in these patients, we're going to make sure that we don't have any these complications. So to make sure that the patient doesn't have fractures, we're going to be doing a DEXA scan, and to make sure that the levels of vitamin D and calcium are in the normal levels. In case that we find patients with osteoporosis or osteopenia, we can choose to treat them with bisphosphonates. If we are having a thromboembolic disease, this is going to be also present in patients that have high-risk situation. These patients are going to be having a family history or a past history of venous thromboembolism. They have a history of immobility, low levels of albumin, and high leukocyte count. As I told you before, these patients, when they have low gamma globulin, they're going to be more susceptible to infections. So we are going to be having more controls, medical controls with these patients, and also vaccination. One of the most frequently diseases that we can find in these patients are pneumonia, osteomyelitis, and endocarditis. And also the renal disease is something that we need to discuss about in these patients, and we need to have control, and in some cases we're going to be doing a kidney biopsy. And some of the treatments that they're using for these patients is bortezomib and rituximab. Some of the treatment that we use in these patients are going to be off-label. They're going to be FDA approved for other diseases, but not for MGUS. In case of the neuropathy, this is usually not treated in patients with MGUS, but we're going to be treating them when we saw many symptoms in this patient that they're going to be affecting their life. The first line treatment for MGUS and neuropathy is plasmapheresis, and this is going to be 3 to 5 times per week, every other day. The other treatments that are available for the neuropathy in MGUS is rituximab, IVIG, corticosteroid, and fludarabine. All of these treatments are going to be off-label, so they're approved for other diseases but not for MGUS. But we can use it in patients if we don't see any improvement with the first line treatment, that is plasmapheresis. About the prognosis, as I told you before, there is a risk of progression to multiple myeloma that is 1% per year, and this percentage does not decrease with time. And it's also related to the activation of SIMIC that is related to the clonal hypermutation of the B cells and the reduced capacity to secrete other IG. The median survival of MGUS patients is slightly shorter than regular population. It's going to be for 12 years to 8 years. And the morbidity of this pathology is about the complications that the patient can have, usually for bacterial infections and renal diseases. And we're going to discuss about what we need to do with the patients if we saw about the levels of M protein levels. If we saw that the patient have less than 1 per 5 grams per deciliter, the life expectancy is going to be similar to the normal population. For the recommendations, we need to make sure that we put the patients in high risk and low risk depending on the levels of M protein, the abnormal free chain ratio, and also about the levels of IG that they have. If they have, for example, an IgM, this is the type, and we saw that the levels of IgA and IgD are lower than they were before, this patient is going to be having a high risk instead of a low risk. If we have 3 high risk factors, this patient is going to be put in the high risk, and this patient has to have an annual serum electrophoresis. We're going to be doing serum free light chains, and also we're going to be doing lab tests, creatinine, and serum calcium. This is also useful in patients that have a high intermediate risk and also a low intermediate risk. In patients that they have low risk, they have the M protein less than 1 per 5 grams, that they don't have any chains in the live free chains, and they don't have any risk factor, we only need to be seeing the patient with the physical exam and the history. If the patient is in high risk, we can also use imaging tests. The one that is more useful for this patient is the CT, because it's more sensible than the bone scan. And this is a summary about what we need to do with patients with MGUS. When the patient is diagnosed, we need to make sure that in 3 or 6 months to evaluate the patient to know if they have any symptoms such as bone pain, fatigue, weight loss, something that make us think about multiple myeloma. Then we're going to be doing the laboratory test, that is the serum protein, the electrophoresis, the creatinine, the calcium, and the vitamin D. If we saw any red flag, that's something that tells, okay, with this patient is not having MGUS, but this patient can be having multiple myeloma, we're going to be evaluating for another diseases that are multiple myeloma, amyloidosis, and also a smoldering myeloma. And if we see a progression, this is the treatment that we're going to be using in the patient is disease-related. If we don't see any progression, we're going to be having daily visit to the hospital to make sure that nothing is wrong with the patient. And if we don't have any red flag, the patient have the M protein level less than 1 per 5, and the IgG is normal, and there is normal free chain ratio, the patient is going to be having only physical exam and history. And something that I think that is important to notice is that they make a study in the firefighters that were working in 9/11, and they found that they have more risk factor for the development of MGUS and multiple myeloma. And these patients that they have these diseases, they were having a younger onset of the disease, is going to be presented with the light chains type, and they have a poorer prognosis than the normal population. And as a summary, MGUS, even though patients usually don't have clinical symptoms, there is a risk for progression for multiple myeloma. It's important that we know about the serious complications that the patient may have, and it's recommended to monitor the patient every day, usually annual, to make sure that we're not dealing for a progression to multiple myeloma. And this is going to be a multidisciplinary management, but because it's not going to be treat only with the primary care physician or only with the neurologist, but we're going to be having more help with the oncologist and also hematologist. Thank you for your attention.
Thank you.